And good evening, everybody. So we are expecting more friends to join, but I can see a lot of friends has joined from other courses. So thank you all for joining in. And so today we are going to look into the status of palliative care, not only in India but across the globe, how it is. So we have two eminent faculties today, and I think none of them requires any introduction. But for the sake of some of you may not be knowing, so first of all, I would like to introduce Rajagopal sir. Rajagopal sir is the chairman of Palliative India, and he is the director of Trondheim Institute of Palliative Sciences. He has won a lot of awards, but most importantly, he has won Padma Shri Award in 2018, which is the third highest civilian award in India, and many other things. But I am stopping with that because sir may not like it. So I'm going to Dr. Audit, who is a friend. So Dr. Audit is from Australia. She is a palliative medicine specialist, which is from Australia, Peter MacCallum Cancer Institute and Victoria Comprehensive Center at Melbourne. She has done her PhD in 2020 from Lancaster University in UK for a study which explores the experiences of palliative care doctors in India and Australia of the relief of patient suffering. She is also the founder and chair of a charity called Australian Palliative Link International and the Western Pacific Palliative Care Advice Advocacy Network in 2020. We have been collaborating in palliative care field, and so I'm handing over the mic to the faculties, and it's over to you, sir, and welcome you both.
Dear Odette, hi.
Hi, Dr.
Odette, how many centuries have we been working together so far?
That's a very impolite thing to say, Dr. Raj.
at least a quarter of a century, right?
I think so.
98. Odette, thank you for all the contributions that you have made to this country. You have just been another member of the team. Thank you very much. Dear friends, Dr. Odette will make her presentation, mostly talking about the international scene, and then I'll follow her. Odette, thank you.
Thank you very much. And thank you for this opportunity to join in this refresher course and to meet you all. I'm looking forward to tonight. I'll just share my screen. Can you hear me clearly?
Yes,
Okay.
Dr. Yes.
Lovely, thank you. I'll just get my talk up and let's see how we go. I'll try and, okay, can you see that all right?
Yes, we can.
Great. So in this talk, I'm going to talk about the evolution of palliative care definitions and particularly of this concept of serious health-related suffering and how it's gained a lot of attention and how it's measured. Then also touch on how people are trying to measure the quality of end-of-life care in various studies, global studies, and then also some new resources that might help us assist in defining and measuring quality of end-of-life care. So when you probably all aware of this article by the Lancet Commission, published about 5 years ago now, which describes the lack of access to palliative care and pain relief as an abyss. And when Dr. Raj asked me to, well, when we were talking about this talk, we were wondering why there is a sort of an ongoing lack of awareness of this issue, of this crisis, really, and of pain relief and access to palliative care globally. And I suggested maybe that many of us feel like we are confronted with so many issues that perhaps we're drowning in these issues and we sort of feel that we're overwhelmed. Dr. Raj, however, also wondered whether we might be just running away from some of these difficult things, that perhaps we've developed a kind of perhaps a hard-heartedness or a self-protective impulse not to look in these directions. I must confess that at times, I think that does describe my reaction, that there are times when I do look away and I don't really feel that I'm able to respond in a more positive way, that I need to withdraw. But I think the strategies that we bring to our clinical work can be useful in trying to look at the more global issues as well. And one of Sunil mentioned my PhD study, and I spoke to a number of doctors working in India and Australia, and one of the Indian doctors I spoke to used to go to remote areas in the northeast of India, and she talked about visiting some of these hospitals, and on the first day just seeing a lot of patients feeling totally despondent, that she would need to call her husband and debrief and pray and really try to kind of regroup, because as she said, it was just too much suffering for one human being to encounter. But then over time, over the next few days, as she was there longer, she was able to sort of start breaking down the different aspects of suffering and then start to look at where she could help. And then she said things became a lot more meaningful. So perhaps that's a similar strategy for trying to deal with some of the global dimensions of this challenge. And I'm also reminded by things that Dr. Raj has told me that, that we have chosen, those of us working in this field have chosen to see the suffering, to remove what we can, and then to learn to live with the rest. So these principles, I think, do apply to advocacy and attempting to address the global burden of suffering. So let's just briefly review the evolution of the conceptual underpinnings of palliative care. In the 1960s, when palliative care began, there was really a clear focus on care of the dying and holistic care, person-centered care, but very much around the dying person. And then 20 or so years later, the WHO definition started to broaden a little and talk about no longer being responsible to curative treatment. So not necessarily in the dying phase, but with disease that was no longer curable. And another 20 or so years later, I think we recognize it's often hard to find these exact points in the patient's disease trajectory. And so then there was, and people were missing out on what could be useful palliation. So then it was looking at early referral and integration into acute care. Some people call this parallel care. And then most recently, again, because still people were missing out on what palliative care could offer in improving their comfort, the move turned to, it's been much more around identifying serious health-related suffering. And so the new definition of palliative care is really focused on this idea of serious health-related suffering across all ages, still especially with the focus on those who are nearing the end of life, and still with the focus on improving the quality of life for families as well as for patients. So this concept of serious health-related suffering has been really at the core of this Lancet Commission report, and has been defined by the Lancet Commission group. I know we don't have a lot of time to go into the methodology, but in essence, they identified 20 life-limiting or life-threatening conditions and 15 associated physical and psychological symptoms associated with those conditions. And then they tried to estimate the duration of each type of suffering for each condition, and then an estimate of the number of patients with each condition and with each type of suffering associated with that condition, and then to calculate the number of days of each type of serious health-related suffering with each condition. So the whole concept, I guess, is based, or the numbers that have come up are really based on all these estimates and best calculations based on the data available to the Commission. And you can search for the serious health-related suffering burden according to on the International Association of Hospice and Palliative Care website. You can find this database, and you can look for serious health-related suffering by country or by income group and by region. And here you can see, if you click on India, you can see that the count of people with serious health-related suffering is estimated to be over 7 million people. So it's useful to have a look at this website and see what you can glean from it and use it in your advocacy. There are other methods of assessing end-of-life care and the burden of suffering, and I'll mention 2 or 3 of these. So there were reports produced by a group called the Economic Intelligence Unit, called Quality of Dying Reports, and they have produced 3 reports now, actually, 2010, 15, and one last 2021. There's also some interesting studies coming out of Singapore, led by a group from Duke's University there and the Lien Centre, and involving a number of countries, particularly in Asia. And then also the monitoring of opioid use through the International Narcotics Control Board is also a very useful way of estimating how well we are meeting the needs of patients in pain globally. So the Quality of Dying reports from the Economic Intelligence Unit, they have identified, their methodology involves identifying 20 indicators across 5 different categories: palliative and healthcare environment, human resources, affordability of care, quality of care, and community engagement. And each has a number of indicators which have been given a certain weighting. They have looked at trying to assess quality of dying across 80 or so countries. This was the data from 2015. And the general points, and unfortunately it's a recurring theme, is that countries that are from the higher income areas of the world always seem to perform better when it comes to quality of dying assessments than countries from lower and middle income. So there are gross global inequities in this area. So I think you can find India, in 2015, India was ranked 67th in terms of this quality of death index overall score. In 2021, however, India had improved its score, which is great, and was now rating at 59 on this scale. Again, like all the methodologies, In all these measures, there are critiques, there are limitations, but I guess the important thing is that there is now effort to actually document quality of dying as an important health outcome. The studies coming from Duke's include this one, which is called the Approach study. Approach stands for Asian Patient Perspectives Regarding Oncology Awareness, Care and Health. And there have been a number of studies in this sort of cohort of studies. This one was trying to assess the impact of socioeconomic factors on suffering at the end of life. Large study with over 1,300 patients, stage 4 cancer patients, treated in public hospitals in 5 countries: China, Sri Lanka, India, Vietnam, and Myanmar. And they found that suffering in several domains, so they included physical, financial, spiritual, social, and pain domains, was greater in people from lower socioeconomic status households and also people with lower education. So if you have higher education and a better economic status, you have a double advantage. Also, they noted that disadvantage may accumulate over time, such that low socioeconomic status elderly experience greater suffering in the non-physical dimensions, particularly social suffering appeared to be greater. Another study from this group involved a very comprehensive methodology. The aim was to compare countries in a similar way to the quality of the Lien Economic Intelligence Unit compares countries, but in this study, they developed a different criteria for evaluating the quality of dying, and their criteria included information from patients or from caregivers of deceased patients who were asked to quantify the relative importance of a number of indicators identified in the literature, and then also included the country experts' evaluation of the quality of care in their countries. These are the indicators that they derived from their scoping review of literature. So managing pain, a clean space, being treated with kindness, quality of life, extending treatments, and so forth. The end result of the study was to come up with a systematic ranking and grading of the countries that were participating based on the information from 181 experts from those countries. Again, you find the advantage of coming from a high-income country, although Costa Rica actually, as an upper middle-income country, also scored highly. But nearly half the countries in the study received a grade of D or F, F being the lowest grade in terms of quality of dying. Now turning to another way of sort of estimating access to care, quality care at the end of life. For a long time, opioid consumption has been used as a sort of surrogate marker of how well we're doing in providing pain relief and palliative care globally. And the World Drug Report in 2021 continues to show the critical low availability of controlled pain medication in low and middle income countries, something that I'm sure most of you are very aware of in your work in India and your studies of palliative care in India. And there are a number of measures of global consumption. For my simple brain, I find the the graphs on the right there showing consumption milligrams per person, easier to understand than the statistical defined daily dose measures used in the World Drug Report. But you can see that for the WIPRO region is the Western Pacific region, it's a WHO region. The SERO region is the Southeast Asian region. Both would show very low consumption of essential controlled medicines. Similarly, in the Eastern Mediterranean region, it's less than 1 milligram, and this contrasts dramatically with the European region, which would have 10 milligrams per person of morphine and other drugs also higher consumption. So again, we see this inequity of access. This is a graph from the International Narcotics Control Board, again showing the gross sort of disparities. From one would suggest perhaps overconsumption, perhaps in North America, to either no data or absolutely minimal consumption in many other parts of the world. And we don't really know what the right level of consumption is, but we can say confidently that zero is definitely not a right level of consumption, and that we shouldn't have this degree of disparity across the world. So the number of international agencies and bodies obviously very concerned about the situation, and in 2020, and I think another similar statement since then, by the International Narcotics Control Board, World Health Organization, the United Nations Office of Drugs and Crime, all call on the need for governments to ensure that procurement and supply of controlled medicines meets the needs of their patients. And it's good to see that the current chair of the Commission for Narcotic Drugs, the United Nations body that is responsible for drug-related matters, has taken a very strong, has a very strong focus on improving access to medicines. Now, the last couple of slides, I was really taken with this quote from Dr. Kera Mate from the Institute of Health Improvement in the US. He's a focus on quality, an expert on quality improvement. He talks about focusing on the most marginalized, and that if we do that, we get to universal goals of healthcare faster and more effectively than if we do not. And the example they used was this one in Alaska, where they actually achieved higher rates of vaccination than any other state in the US, because they did just that. They went out to the most remote and the most marginalized communities as their first priority. And I thought that was a really important concept, and one that should really inspire us to focus on the patients who are most disadvantaged as our priorities. Now, there are just a number of resources. This is turning towards the resources that help us. So the WHO has put out a universal health coverage compendium that includes essential palliative care information, such as the services, the interventions, and how palliative care can be linked in with other programs and the evidence-based resources. So this could be a useful resource for thinking and planning programs to increase the scope of palliative care. In addition, there are two new resources from WHO, one on quality health services and palliative care, and another on actionable indicators that countries and services can use to track their progress in developing palliative care. And these are grouped as essential core indicators and strategic indicators for more advanced settings. So I think that's all I need to say, and I'm sure Dr. Raj will build on some of these points in his talk. I'm very happy to take some questions.
Is it okay if you take questions at last?
Sure.
Yeah, I think certain presentation now.
Thank you, Sunil. Odette, thank you. That was brilliant. So much of the recent advances given with the literature. Odette, by convention, usually we share the presentation with all the participants. Please let Raju know if that's okay with you.
Sure.
Thank you. Friends, so Dr. Odette Sprite has told you where we are about palliative care globally, what we think it is, which concept has changed enormously. I'm just grounding that on the Indian scenario. That's what I'm trying to do. I think Odette has already talked about the numbers. The Lancet Commission report estimates that in India, at least 7 million Indians are in serious health-related suffering. But please remember, Lancet Commission took into consideration only some 20 different disease conditions. There are many outside of them that do not come into the statistics. So if we include them, it's not going to be 7 million. It would be more like 10 million or 1 crore. Those are the numbers that are more realistic. Together, this is the problem that we have to address. Today, various estimates are made, but nobody would say that more than 4% of Indians have access to palliative care. It's as bad as that, though we have been working at it for a quarter of a century. Can I share my screen, Raju?
Yes, sir.
Though it is, when you say 7 million or 10 million, they seem to be just numbers. Each one of those 7 or 10 million would have a great story behind that, the story of suffering behind that. Like this man who had attempted suicide only because of pain, and whose 11 and 9-year-old children had to push him up and save his life, cut him down and bring him down. The scars that those children live with would be in their minds. The numbers are more than 26,000 people every year. That's the number of people who succeed in committing suicide. How many would be attempting? How many would be attempting, wishing they had the strength to try? These are questions that we need to ask ourselves. Like what I said, we cannot address all of them together. But if we keep trying, a few at a time, the numbers would swell. That is not the only problem that our patients have. We also have the problem that India is one of the worst countries in the world, certainly one of the worst 12, as far as destruction of human beings by catastrophic health expenditure happens. I would like you to answer this question for this man. This man had advanced cancer of the cheek, which was getting to obstruct his throat, so that the doctors put it in a nasogastric tube. But as it went on, he was finding it harder to breathe. So the last entry into the hospital is with breathlessness. I'm just trying to explain the current status of palliative care in the country, where would be the best place to treat this person? Raju, can you administer the poll?
Yes, sir. Yes, sir. So you can see a question in the screen. Choose the most appropriate answer from your end.
So we can see 81% home, 13% hospital room, 6% ICU. Raju, you can stop the poll. Thank you. Thank you for participating, friends. Home, yes, provided we are able to get enough support for the people at home. If they start having severe breathlessness at 2 o'clock in the morning, how will the family manage? If at least, okay, we in our unit provide a 24-hour helpline, but for breathlessness, so little that we can do. I'm not giving an answer for the patient. It will be an individual choice. Most people choose to remain at home, but some would prefer to be in a hospital. But the important thing is they should be receiving palliative care. To the two people who mentioned ICU, let us not think of them as patients, but this could be any one of us. This is in the ICU. What's likely to be done? A tracheostomy. Is that what the man wants? I am putting myself into his place. If the cancer cannot be cured, life with a tracheostomy, prolonged dying process, the disease is still there. I will have to die of something. That stretched out over 2 more months of suffering would not be what I want. This is how Dr. Sankhamitra, a British oncologist of Bengali origin, describes the end-of-life care situation in India, where the poor die in misery of neglect, middle class die in misery of ignorance, the rich die in misery on ventilators. No one gets a pain-free and dignified death. And if you ask me to choose between them, if this man is at home, I would choose that rather than this horror. This is not only a personal opinion. The National Cancer Grid, a collaborative of more than 200 cancer institutions in the country, I have given the reference there, have together come out with this guidelines called Choosing Wisely India. And they say, do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. If the cancer is advanced, that's a time for people to receive love and give love, to be amongst people who are known and familiar and loving, not in a cold ICU. Why am I saying all this? These are some of the problems that people needing palliative care have in our country. Pain doesn't get treated so that people have to try to take their own lives. Catastrophic health expenditure destroys families, and end-of-life care is very improper in our country. For this man, or for me in his position, what would have been kinder is not to isolate the person. Give oxygen if it is actually improving the breathlessness, not to improve the saturation. Use corticosteroids to reduce the peritumor edema, and use small doses of morphine to reduce the sensation of breathlessness. Can we do that? Can we withhold artificial life support or withdraw artificial life support? Again, I have given the reference there. A Supreme Court judgment of 2018 acknowledges the importance of withholding and withdrawing artificial life support. They say it has to be done. But they have also put in impossible procedures to implement it. That becomes a problem. But you should know that legally now, because India does not have an end-of-life care law, this is what holds valid. Raju, can you please show the video?
Yes, sir.
Coming back to this man, we have mentioned all the problems, and you all know what total pain is. Most of you must have seen this video already, but just to describe the realities in our country, I am requesting Raju to show this video of my colleague Smriti Rana, as she was giving a TEDx talk describing what she found as total pain.
Palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood.
Thank you, Raju, thank you. I am coming back to my presentation. Many of you must have seen that already, and you all must be also aware that such problems are something that we try to tackle as a routine. We don't always get to do everything, but as Odette said in the beginning, we try to do what we can, and we try to live with the rest. This process of addressing total pain, including physical, social, and mental well-being, and attention to spiritual aspects. Let me just make it clear once more for anybody who needs to be reminded. This is not something for the end of life, though I mentioned end of life. This is not only for advanced disease alone. This is to start when the suffering starts. Along with disease-modifying or potentially curative treatments, supportive and palliative care has to happen. And since 2002 definition of palliative care by World Health Organization, this has been clearly mentioned that it has to start early. And also, because we have been talking about the patient, we now have to remember the family also, the family that lives with the suffering. So we do not desert the patient desert the family when the person dies, but continue to offer bereavement care as much as we can for as long as we can. One of the things that happens is when you make a routine post-bereavement visit or contact, you find some people who have gone on to complicated grief, which would have destroyed the whole family, and we are able to help with that. And especially the social support measures that Smriti mentioned do not stop when the patients stop. Whatever we can do, we continue to do as long as the need is there. If we are to do this effectively, we have to put into practice what the World Health Assembly asked member countries, all of us, to do in 2014. They asked us to integrate palliative care into health systems at all levels, primary, secondary, and tertiary, across the continuum of care, meaning starting from the beginning of the suffering to the end. This cannot be done by palliative care units alone. To do this, if you see the middle panel, the whole healthcare system will have to accept the principles of palliative care and integrate it into their practice, which to a significant extent seems to be happening in Western European countries, for example, in places like Odette's country, where every oncologist and every clinician may have had some training in palliative care. And palliative care units, specialized units, will care only for those problems that the general health system is unable to handle. And as Smriti pointed out in the video, if we are to address the social issues adequately, particularly, or even to recognize the mental issues, or to connect us with people in physical suffering, we need the engagement of the community. Starting with the community engagement as a foundation, we can build the rest of the palliative care system. Is this doable? Is this just a wild dream? I say it is very much doable. The Astana Declaration of 2018 highlights the point that health for all has to be health with all. The community needs to be engaged. And when we mention the community, it is at all strata. You can see Dr. Sunil in a patient's home trying to help this woman. She would have never walked unless the volunteers, you can see the local volunteer, Mr. Francis, in the background. If they did not provide enough support to help her every day, she would have never walked. In this group today, we have people from various streams of medicine. But I think we also have a former member of the parliament among the audience listening to us, Dr. Manoj. At all levels, this is what changes things. I'll explain why that total involvement becomes necessary. But particularly the community participation is necessary to reach people where they are when they need us. Care at home has to be ensured, otherwise the most needy will never get to us. As Odette said, unless we go for the most marginalized, our healthcare will never be universal. I say we are moving closer in this country. From the time when time when Odette saw us first in the last century, we have been making slow progress. But especially in the last few years, there are many things that are very promising. For example, in 2012, the government of India created the National Program for Palliative Care. Every state government can get some money from the central government for a palliative care program if you go through a certain process. There are certainly numerous things that can be improved in the process, but that is something to be done. The law, apologies for the abbreviation, it is Narcotic Drugs and Psychotropic Substances Act. The NDPS Act was changed by the Indian Parliament in 2014. So the whole country has a unified law and rules, so that if it is implemented by all the state governments, access to opioids is quite possible. And in fact, things are slowly improving in access to opioid medicine for pain relief. And the National Health Policy of 2017 includes palliative care. Earlier, I mentioned that the whole palliative care, whole healthcare system has to accept palliative care approach. This may sound an impossible dream to achieve in our country, but you should know that already national level trainers have been trained and state level trainers have been trained to give basic palliative care instruction to 50,000 family wellness centers all over the country. That's a gigantic beginning, major step to step in progress, and so heartening that from in the last 3 years, undergraduate medical and nursing curricula now include palliative care. There will be an implementation gap between creation of the law, the programs, the policy, and the curriculum to its actual implementation in an unwieldy country like ours with 1/6 of the world's population. It's not easy, but steps are being taken. We are moving in that direction. I'll stop the share, but I'll be ready to come back to the presentation if there are any questions for that. But I'll stop there, and I'm glad we now have some time for discussion.
Thank you, sir. Now we heard about both the global and the Indian situation of palliative care. And if you have any doubts, you can ask.
Good evening, ma'am. I'm Dr. Sashikala. I have a question for Dr. Odette. Can you elaborate a little bit on that last slide of yours, which talked about the indicators, the strategic and core? Please, thank you.
Yes, sure. I'll see if I can get the slide up again, Dr. Sashikala. Just quickly. So you can see here, this is the slide just before it. So I think it was last year or earlier this year, I think last year, that WHO produced these two new technical report documents. One is on quality health services and palliative care, some practical resources to try and facilitate action on quality palliative care. And then linked to that was the second one here, assessing the development of palliative care worldwide. I think from my understanding that this is aimed at or directed towards sort of country level member states, they call it, country level use to help countries to plan and identify what needs to be in place in order to develop comprehensive palliative care services in their country. And they recognize that there's great variation in where countries are starting from at this point in time. And so they've identified that there are what they call core indicators and strategic indicators. So you can see this, I don't know if those, yeah, you can see the two columns here, core and strategic, and you can see that they have kind of divided them into 6 different domains. So for example, the first one, integrated palliative care services. Number 1 of that is the number of specialised palliative care programs. So that ticks both as a core and a strategic indicator. And then under that is the number of specialised palliative care programs for paediatrics. So that is regarded as an indicator, a kind of a next level to aim for once the initial programs are established, then to not to forget, to make sure that paediatric populations are also receiving palliative care. You could argue that it should be both at the same time, but I guess the reality is we have to progress perhaps in stepwise fashion. Dr. Raj, do you want to comment further on that? Is that helpful, Dr.
Shashikala.
Shashikala, yeah. Very much, ma'am. Thank you so much. And it's really heartening to see that there's so much of thinking going on at the global level. And like Sir said, we are looking forward for that number of people whom we have to live with gets lesser and lesser.
Yeah, absolutely.
I have put up the relevant links on the chat box.
Oh, beautiful.
So that people, you can just copy that and paste
Thank you.
it, and both documents are available there.
It's marvelous. There's a lot of resources available. So thank you for doing that. I'll stop sharing.
Sir, there is a question from Dr. Punita Vati Dhanasekaran. Should I be a member of any professional body to run a palliative care unit in my medical college?
Dr. Punita, the one-word answer is no. You don't have to be a member of any professional body except your registration in the India's Medical Council. But having said that, doing palliative care without proper training obviously is not advisable. And to access opioids, you need training in palliative care. The nature of the training is not defined by the rules, but it does say that you have to be trained, and that is fairly obvious. That's an obvious need. And secondly, individual state governments may have different rules for running any healthcare institution. For example, in Delhi, any organization will have to be registered with the director of nursing homes. In my state of Kerala, if there is an inpatient unit, you have to be registered with a local self-government body. So that would be something different from state to state. Though it is, you don't have to be a member, I would strongly recommend that you should become a member of Indian Association of Palliative Care, just so that all new information reaches you. And certainly we would like you to keep in touch with us. Dr. Kale, you ask, even today, oncosurgeons are reluctant to send patients to palliative care center as soon as it is diagnosed. Dr. Kale, sending all patients to you means you will not be able to handle the load, which is where the integration comes in. I am hoping that all oncologists will learn enough palliative care so that if somebody has a moderate pain, they'll be able to treat the pain themselves. Is that possible? Well, Cancer Cancer Center in Silchar, Assam, and the Himalayan Institute in Dehradun has given every training in pain management. We had the privilege of working with them, to every single doctor and nurse in the hospital. They all prescribe the required analgesics, including morphine. And only if there is a difficult pain, it has to go to the palliative care center. And Dr. Kale, the vast majority of oncologists today have not started referring patients for palliative care. That is true. But things are changing, though slowly. We cannot force it. There is no way of forcing it in our country. But the National Cancer Grid, the organization of all cancer centers, strongly making recommendations for inclusion of palliative care. And that is certainly a way forward. Odette, you have put up this article about how views of oncologists and hematologists impact palliative care referral, a systematic review by Dr. Naveen Salins and colleagues. Thank you. Thank you, Odette. Dr. Naveen Salins is doing wonderful work. Most of us are amateurish. With a scientific approach and with excellent quality research, he's changing the palliative care scene in the country. What is the role of the MD palliative medicine degree in this situation? regarding palliative care in India. Dr. Savitri, that is certainly the promise of the future, both MD and DNB. But remember also that today, between MD and DNB, only about 20 doctors a year can get trained in this country of 1.38 billion people. How many thousands of palliative care physicians will be necessary? The MDs and DNBs are going to be very important. Setting the benchmark, doing research, teaching us all quality palliative care. They will have a very, very important role to do in the future. But very few institutions in the country now have the capacity to take on MD, specifically because of some regulations regarding bed strength, for example. Most of our work is in patients' homes. Every home visit should be considered a bed, then it would have been easier. But as it is now, very few institutions can run it.
Can I comment on that, Raj?
Please, Odette.
Look, I think the as you say, maybe the scope, the need is so huge that programs like this, I think, and multiplying programs like this to really upskill as many doctors as possible to have palliative approach, palliative skills is really the answer, because you know, and having those MD doctors maybe to try to spearhead and do research and try and do that level of work is probably, but more than the clinical work is probably where they will find their greatest contribution, rather than but what I've always been impressed by in India actually is the skill set of, when I say general clinician, I mean specialists, but not necessarily palliative care specialists. People have enormous clinical experience. So this is just a kind of bringing this set of skills to their already substantial skill set.
Dr. Ariba Bisati endorses the idea of integration. Every doctor should learn it, but as she underlines, a separate palliative care facility is also needed. Thank you, Dr. Ariba. Odette, I think our Raju, there is a case presentation today, right?
Yes, sir, there is.
So she's going to ask us to stop any second now. Odette, you had put up that image of a poster for APLI. Would you like to tell everybody about APLI just for a minute, just an introduction?
Thank you. So we started this group about in 1986, I think it was, with the idea of really fostering links between Australian palliative care providers, doctors and nurses, and colleagues in the Asia Pacific. But our strongest link has always been with Pallium India and with India in general. And our sort of main activity over the last 10 or so years has been a project called Project Hamrahi, which we collaborate with Pallium India to help with some mentoring of relatively new palliative care services in India by having an Australian team connected to that service to help them. And in the last 2 years with COVID, rather than going in person, we've been setting up virtual links and running Echo Hamrahi sessions, again in collaboration with Pallium India. So,
Raju, if you will permit one last question. Dr. Manoj, I can't see you. I get the right person, right? The former member of parliament.
Yes, sir. Yes, sir.
Dr. Manoj, pleased to meet you again. Dr. Manoj must have undertaken palliative care training again a quarter of a century back. Went into politics, was one of the people running the country. Thank you, Dr. Manoj. Manoj's question is to you. In
Yes,
Kerala, palliative care is essential part of every local self-government body. In fact, no budget allocation will be final till palliative care is included as part of the panchayat's annual budget. So he's asking, is community level palliative care popular in Australia?
Yes, thank you for that question, Dr. Manoj. Yes, it is. We try to have a sort of comprehensive approach to palliative care so that it's available to wherever the patient is, be they at home, be they in the hospital, or perhaps in a nursing home or in a specialised palliative care unit. Kerala has a pretty extraordinary model of community palliative care, which has enormous volunteer support. I don't know if we can match that in Australia. It's more professional health provider level, although most community palliative care services also do have a volunteer program. Volunteers get involved with providing support for patients in their homes, driving them to appointments, doing shopping, doing all that, company keeping. So, but we don't have, to my knowledge, we don't have programs that help pay for the education of children or some of the really wonderful things that I know happen in Kerala. But yes, we do. I don't think you can really have, because of most patients want to be at home, to die at home if possible, or to spend as much time as possible at home, you really do need to have the community component of palliative care to support them to do that for as long as possible. Thank you.
Thank you. Thank you.
Thank you.
Thank you. I think we will move on to the patient story now. So which will be presented by Dr. Dheeraj Sumir. Dr. Dheeraj, it's over to you.
Hi, good evening, Dr. Odette, Professor Rajagopal. I am back again. This is my third course with Palliative India. I think sharing is caring and caring is learning. So it's a continuous process. I always come for Professor Rajagopal sir only. Please, next slide, please. This is a 61-year-old male. He is primary carcinoma rectum with metastasis to liver and adrenals. He had a pathological fracture of L1 vertebra. He underwent a surgical resection of rectum and received chemoradiation. He is a known case of hypertension and type 2 diabetes mellitus. Next, please. In presenting complaint, he had moderate pain over low back with inability to walk. He also is complaining of constipation for last 2-3 days, and he has loss of appetite because he is a bedridden patient. He doesn't feel anything to eat. Next, please. He's a carcinoma upper rectum with mets in liver and adrenal and vertebrae. He is post-lap loop ileostomy. He is post-operative, post-chemotherapy, post-radiotherapy status with recurrence. He had L1 fracture with degenerative disc disease at L3, L4 and L4, L5 levels. When he came to me, he was anxious, he was fearful, he was conscious oriented, temperature was around 98, pulse was 82, respiration was normal, 20 breaths per minute. BP again was normal, 120/70. In systemic examination, everything looked okay. Local examination of the back, when we examined the back, he had moderately severe back pain. The VAS score was around 7/10. He had acute and chronic low back pain with radiculopathy. Few of the neurological changes, the skin was changing, there were no hairs. He had no bladder and bowel involvement. We did a SRL, it was positive. He remains in bed all day with pain only. Next, please. We did the investigation, primary investigation. His HB were 10, TLC was around 12,000, neutrophils were, polys were 80, lymphocyte 18, platelets were fine, renal parameters were normal. He was carrying a MRI that was suggestive of lumbar myospasm. There was L1 fracture with degenerative disc at L3, L4 and L4, L5 levels. Next, please. In psychological aspects, this was a 61-year-old married man living with his family and owns a small business. He had a small shop in Chandigarh only. He has 2 siblings and one is married and living separately, and he was not supporting his father. The younger son has left his job and taking care of the business, which is into losses and wishes to go to Canada. He was just expecting that his father dies and he can move on. He's a Hindu and believes that this is his karma and has now started believing that there is no God. He knows it is his destiny and do not want family to spend on him for his treatment. But the family, the wife and the son somehow wanted him to have a pain-free life or a death. Next, please. Medication, he was never started on any medication. He was going from pillar to post, looking for some options. He was seen by the oncologist who had given him chemotherapy and everything. For his spine, he suggested him to go for a radiation, but the radiation oncologist marked him for a neurosurgeon. The neurosurgeon gave him the option of a spinal fixation. Then he went to a pain physician who advised them multi-level root blocks and percutaneous vertebroplasty. Ultimately, he came to me for palliative care. The main concerns were pain, pain-free life or a death, and financial problems. In summary, sir, he was a 61-year-old carcinoma rectum with metastasis to liver and adrenals and pathological fracture at L1 vertebra with acute pain. Next, please. Sir, in discussion points with the flavor of today's topic, do we need to provide palliative care for this patient? Does any intervention is going to help? What are the problems faced by this patient? Can we support this patient? And is palliative medicine the answer? It is open now. The form is open for the answer, sir. And your thoughts?
Dr. Dheeraj,
Yes.
so happy to, Dr. Dheeraj, so happy to hear your presentation, particularly because you are from Punjab.
Yes, sir.
Where one of the most advanced states in the country, unfortunately, except not in palliative care. So you are going to be the leader for palliative care in the whole state with all its attendance problems. So happy to hear this.
Thank you, sir. Thank you.
I think the answer to the first question is very easy. Most certainly, of course. But can I leave all? Would you like to start the discussion on his questions?
Yeah, thank you. And thank you, Dr. Dheeraj. Very important example of a patient in need. So yes, definitely, I would say palliative care is based on the definition of serious health-related suffering. It's definitely appropriate for him to have palliative care. He's clearly suffering on a number of levels: pain, terrible pain, existential suffering, social and financial suffering, possibly depression. And also his prognosis is poor. He has a life-limiting illness. I would suggest that the radiation oncologist and the neurosurgeon and the interventional pain specialists are all attempting to palliate this man using the skills available to them, because whatever is done is really palliation in this patient. So I think we have we have a problem a little bit here that people talk about the patient is now palliative, and it's a kind of code for they're now dying, but I'm always saying, look, once we know a patient's disease is incurable, really most of what we're trying to do in medicine is to palliate. We're not curing, and therefore what we're trying to work out is what's the best form of palliation, and that decision's based on not just his clinical features, but also his priorities, the social dimensions, the fact he doesn't want to spend a lot of money. He's trying not to take that money away from his family's future, things like that. So, and of course, baseline analgesia is the big gap here. So I won't comment on that. I'll let others comment on what they think might be a good way to palliate his pain.
Was somebody trying to say something in between?
No.
No, okay. Dr. Dheeraj, can you go back to the last slide for me? No, the previous one. One of the problems that we often have in our country is that there is usually no general practitioner involved in the care. Nobody really to coordinate. One of our associates, a journalist who wrote about her father's illness, said the doctors had broken him down to segments that only they could put back together. So here is something that we see frequently. One oncologist has radiation, but radiation sends to neuro. This man already has some neurological deficit. I fear that we give him good pain relief. He tries to walk and may get paraplegia. By no means, I am certainly not an oncologist, but ordinarily, I would have done the same thing. I would have sent him to the radiation oncologist for immediate palliative radiation, which might protect from worsening paralysis. But there must be some reason why in this case it was not done. My only point is just giving a referral and sending him in a trolley means he moves from OP to OP, and half the rest of his life will be spent on a trolley in hospital corridors. One of the important things that Sunil or I or any of us would do would be to connect by phone to an individual doctor, arrange a time, and after a conversation, get that doctor to see the patient. Dr. Dheeraj, thank you. Will you come back to your discussion points?
My issue is the palliation. By and large, we as anesthetic, like I have a anesthesia background, sir. I am now doing pain also and palliation also. By and large, most of the pain physicians, what they think palliation is just pain management only. They will be doing lot of blocking, lot of needling. Even I have seen, sir, if the patient is having a prognosis of 6 months only, they are doing spinal cord stimulation or something like stuff like hi-fi stuff like that will cost you around 10 lakhs or something. How justifiable is people doing all these procedures?
Dr. Dheeraj, I think I respect the anger that you are showing on behalf of the patient. That is true empathy. Thank you for being so humane. I must confess that I used to do precisely what those pain physicians used to do. There was a time when I see somebody with I'm an anesthetist by myself, Dr. Dheeraj, yes, like you.
Yes, yes, sir.
And as a young anesthesiologist, if I see somebody with pain, I was already looking for a needle, ready to poke the needle into any place.
True, sir.
Certainly, nerve blocks have a relevance in a certain percentage of patients, maybe about 5% of people with cancer. I totally agree with you that in this case, already he is financially destroyed. Subjecting him to expensive modalities would be unkind. I would like, I'm an anesthetist, whereas Odette is a general medicine, internal medicine person, and would be able to comment better. But I would have considered that a single fraction palliative radiation immediately and concurrent administration of analgesics, instruction to the patient that maybe the radiation will take about 1 to 2 weeks to come to full effect. Weight bearing during that time may be dangerous. And medical management of pain with opioids and other analgesics, that would be the way of handling this pain. About how else we can support, we will come to that. But Odette, any comment about the management of the pain itself?
No, I agree with what you've said, Dr. Raj. This man does need medical analgesia, strong opioids, possibly non-steroidal paracetamol, and probably a neuropathic agent. And I agree, radiotherapy, but I don't know if there's instability of the fracture, whether that was why the radiation oncologist wanted him to be seen by a neurosurgeon, but nevertheless, I would generally think radiotherapy would give him the most rapid relief. There was something else I was thinking of saying, but that's gone now.
But Dr. Dheeraj, thank you. Odette, thank you. Dr. Dheeraj, the man also has, wait a minute, Dr. Dheeraj, you have access to oral morphine?
Yes, sir.
Okay. So happy to hear that. Dr. Dheeraj, what is man's major social issues? What do you think could be done in the setting that you are in? What can be done?
So first thing, he has a disconnect with God. He has a disconnect with society. We need to make him connect to. We should give him a hope that God is there. God is kind. We should financially support him through some community awareness, making his elder son, who has is discord with his father, know the condition of his father, that he is dying. He should be supported financially, and I would wish to give him freedom from pain through medication only.
So I'll come back to you, Dr. Dheeraj, and Odette about this. But this man may be believing that God has deserted him. And the solution for that spiritual pain, I would say, is not to tell him, no, God will save you. God will look after everything. Instead, to give him that pain relief, to convey to him that you care for him. And perhaps when you have done your best, the man will come back to you, Dr. Dheeraj, and say, I thought God had deserted me, but he has not. He sent you to me. So generally, preaching about God is rather difficult for the person who is angry with God. Instead, you will be making God manifest to him through your actions and your team members' actions. Odette, I want to comment on that.
No, I agree. All those areas to sort of understand his suffering and be open to hearing. I mean, I do remember doctors telling me, Indian doctors telling me, that patients don't expect us to be interested in these dimensions of their experience. So the mere act of that open, asking him for his showing that you are interested in his and these dimensions of his suffering is a very therapeutic act. And we don't have to have the answers, but I think showing the patient that we understand that their suffering is in many different levels is quite important. And I remember what I was thinking before, and it's going back more to the physical, so apologies for jumping around, but I don't know how much of his pain is his chronic pain. And, you know, has this man been suffering pain for a very long time, and that can be very demoralizing and very soul destroying, if you like. So yes, I agree. We're not. Anyway, thank you.
Dr. Kale has made a comment. Mindset of curative doctors and palliative care doctor is different. Yes, I mean, like, unless you have had palliative care training, everybody is taught to diagnose a disease and to treat a disease. That's all. That's what people have been taught. People will continue to do that. So both possibly need to change. And we in palliative care need to keep reminding ourselves that we should always think of disease treatment also, like we mentioned the radiation. And today, so many diseases are amenable to modern therapeutic agents. Maybe some are affordable to some people. So we need to be aware of the possibilities of disease-specific treatment. And gradually, thankfully, more and more clinicians, specialist doctors are becoming aware of palliative care. We did we did 2 courses for oncologists. So between them, Raju's courses, 2 courses, at least 60 oncologists all over the country have had a basic palliative care training. This is in addition to any training that they have had elsewhere. Neurologists are getting trained in palliative care. More than 75 have gone through a basic palliative care training. Currently, Sunil, I don't know, the respiratory pulmonologist course is also happening. So gradually things are improving. We have something to look forward to. Dr. Moli, a man's search for God. I actually have seen this, Moli. A man who was cursing God. There's no God, there's no such thing as God, etc. And he held on to one of our nurses' hands and said, Moli, I thought there was no God, but there is. He sent you to me as an angel. Rather than preaching God, that's what I mean by making God manifest in ourselves by giving the person human love and care. That is the best way of spiritual support when somebody is challenging God, I think. Dr. Christopher's question in the chat box. Yes, Dr. Christopher, when somebody's physical pain is overpowering, there is no mind space for anything else. Somebody going there and preaching God at that time, he will kick at you. Mind is full of that physical pain. As far as possible, we'll address it immediately and concurrently start addressing the others. So Dr. Christopher totally agreed. That is the approach. Dr. Punita, I think in this case, usually the international recommendation is for a single fraction radiation in a situation like this, not divided into multiple fractions. But many corporate hospitals do not do it. They give 10 fractions. Maybe there is a financial angle to it. So very often I have a feeling that they are more likely to get rational treatment in a government hospital, but I shouldn't generalize. In many government hospital oncology departments, radiation is low cost or no cost sometimes. This pain seems to be due to degeneration. It is a radiating pain, is that?
Yes, sir.
In which case, doctor, the radiation is still important to prevent a collapse of the vertebra and paraplegia. But if any nociceptive bone pain will be helped by palliative radiation, right? Maybe I don't know about how much it will reduce a nerve compression pain. Dr. Odette, did you see Molly's question? Dr. Molly Thomas's question?
Yes, I did. I don't think it would help that, but I guess they're trying to distinguish between what was pre-existing pain and what is now due to this L1 fracture. But certainly if he has back tenderness over the L1 and any sort of radicular pain in the L1 dermatome, then you would be, I think radiotherapy could well help. Maybe steroids could also help in this patient, especially if there's a risk of cord compression.
So, Dr. Dheeraj, can you put that slide on and show me the last but 2 slides? Shashigala is asking, how could, what all could Dheeraj do? Oh, time is up. No, go back 2 slides, Dr. Dheeraj. The previous one with the social issues. So we have been talking a lot about pain management, but the family has financial issues. We talked about, we cannot solve all those problems, but we can do one very important thing. We can avoid any needless treatment. He is likely to be bothered by many interventions that he has been advised to have, and most of them will be destroying the family financially further. He believed in Hinduism, but he now thinks that there is no God, and we talked about how to take care of that to the best of our ability. And he doesn't want the family to spend on him for his treatment. And I also believe that expensive treatments will not be necessary. Dr. Dheeraj will take care of his pain and make his life as full and worth living as possible with the remaining time he has. So that is the strategy, Shashigala. Any particular question? Yes, Dr. Christopher, neuropathic pain will respond poorly to radiation. Yes. The time is up. So now this is the time when Raju will be getting annoyed if we continue talking about it.
So Dr. Chandran says radiotherapy is disease directed, which is causing the pain, and as has said, to prevent localized disease progression and reduce the requirement of analysis.
So, to Christopher also, the pain will be multimodal. There will be the bone pain is very much likely to be there. If there is movement-related pain, that also is likely to be significant. With radiation, we will be correcting only the local bone pain, and the neuropathic pain will have to be addressed with neuropathic pain management, including tricyclics, anticonvulsants. But first and foremost, what Odette said, immediate corticosteroids might be the most useful thing. Thank you, everybody. Sunil, back to you.
Thank you, everyone. Thank you, Dr. Raj.
Thank you.